So before I show you guys two ECGs about the unstable angina and non-ST elevation MI, there are something which I want to talk about. There are, as already mentioned, there are three walls of the heart. Heart is sitting like a fist on the diaphragm. It has got one inferior wall which is right on top of the diaphragm. This is the inferior wall, and heart has one lateral wall and anterior wall. So there are three main walls of the heart: anterior wall, lateral wall, and inferior wall. This inferior wall is supplied by the right coronary artery. This lateral wall is supplied by the left circumflex artery, and this anterior wall is supplied by the left anterior descending artery. On the ECG paper, this inferior wall is represented by leads 2, 3 AVF, lateral wall is represented by 1 AVL, and anterior wall as a whole is represented by V1 to V6. But this part of the anterior wall of the heart is represented on the ECG by V1 and V2 because they are very near to the this septum. So V1 and V2 are famously known as anteroseptal leads. V5 and V6 are located on the lateral side of the anterior wall. So V5 and V6 are called anterolateral. And V3 and V4, they are located here and they are known as pure anterior leads. So anterior chest leads are divided into three subgroups of V1, V2 anteroseptal, V3, V4 pure anterior, and V5, V6 anterolateral. 1 and AVL are the two limb leads which represent lateral wall, and 2, 3 and AVF are two three limb leads which represent inferior wall on the ECG paper. AVR is actually not looking at any wall. It may look at a very small portion of the posterior wall, but as a whole, it doesn't represent any wall. It doesn't look at any wall. Heart has got three coronary arteries. One is right coronary artery, which is known as RCA. This is on the right side of the heart. This is right coronary artery. It supplies inferior wall and it supplies 60% of the time SA node, and it also supplies the septum, right atrium, and right ventricle. Then left main stem divides into left anterior descending artery and left circumflex artery. Left anterior descending artery supplies majority portion of the anterior part of the ventricles, and left circumflex artery, it is on the left side of the heart and it supplies lateral wall, and 40% of the time it also supplies SA node. And there are two branches of the right coronary artery. One is posterior descending artery and one is right marginal artery. Whichever of the two, right coronary artery and left circumflex artery, gives off posterior descending artery is known as the dominant coronary artery of the heart. So there are three coronary arteries of the heart. Right coronary artery, it supplies right atrium, right ventricle, septum, inferior wall, and 60% of the time it supplies SA node. Left circumflex artery supplies lateral wall and 40% of the time it also supplies SA node. And left anterior descending artery, it supplies anterior wall. This is another very important diagram, and this is a table which shows that ECG leads 1 and AVL, they are representing the lateral wall of the heart, and that lateral wall is being supplied by the left circumflex artery. So if there is any change of T wave inversions or ST depression, it represents lateral wall ischemia, and probably the problem or thrombus is in the left circumflex artery. Leads 2, 3 and AVF, they represents inferior wall, and inferior wall is supplied by the right coronary artery. So the problem in the right coronary artery affects inferior wall, and that is shown on the ECG in the leads 2, 3 and AVF. Leads V1, V2, V3, V4, V5 and V6, they are representing anterior wall, and that anterior wall is being supplied by left anterior descending artery. So there are chances that if we see a problem in lead V1 to V6, or at least in two of them, then the wall ischemia would be in the anterior wall, and the artery, culprit artery, can be left anterior descending, which is actually confirmed through the angiography. Okay, now if we look at this scheme of actually ECG leads, here we see that in the black, lead 1 and AVL, they represent lateral wall. In blue, it's lead 2, 3 and AVF, they represent inferior wall. And in green, it's lead V1, V2, V3, V4, V5 and V6, and it represents anterior wall. AVR does not represent any of the lead, any of the wall. These 6 are the limb leads, and these in green 6 leads are chest leads. Limb leads are all are positive deflections except AVR, and in chest leads, as we move from V1 to V6, R keeps on becoming larger and SB keeps on becoming smaller. It's a separate topic. But so here we see, whenever you look at the ECG, there are 3 sets of the leads which represents particular wall, and those particular walls are supplied by a specific artery. 1 and AVL lateral wall, and left circumflex artery supplying the lateral wall. 2-3 AVF inferior wall, and this inferior wall is being supplied by the right coronary artery. And V1 to V6 are anterior wall, and this is being supplied by the left anterior descending artery. V1 to V2 anteroseptal, V5 to V6 anterolateral, and V3 to V4 pure anterior leads. Now if you look at this ECG, here you can appreciate AVR is negative. 1 and AVL, they represent and lateral wall, but of the two, 1 and AVL, only AVL has got a T-wave inversion. So this is not important, because both of these, at least 2 contagious lead of any set, should have the change to qualify for the ischemic change. So lateral wall ischemia is ruled out. This is lead 2, 3 and AVF, they represent inferior wall. There is no T-wave inversions, no ST depression, so there is no inferior wall ischemia. But when you look at the anterior wall, lead V1 has got this symmetrical T-wave inversions, V2 has got this symmetrical T-wave inversions, V3 has this T-wave inversions, and there is no T-wave inversion other than these 3. So there is an ongoing anteroseptal ischemia. So this anteroseptal ischemia represents that anterior wall ischemia is going on. So when a patient comes with a chest pain and you get an ECG like this one, and with the chest pain, restlessness, irritability, sweating, shortness of breath, and if there is ECG changes like this, you need to send cardiac enzyme, and you need to manage the patient according to the acute coronary syndrome protocol if you clinically suspect that this change is related with the patient's presentation. So this is T-wave inversions. This is another ECG where again you see that if we look at AVR, this is negative, so the limb leads are placed rightly. If you look at lead 1 and AVL, there is a minor ST going high, but this is not as high in the lead 1 as it's in AVL. So this change doesn't look significant. So lateral wall ischemia may not be there. But when you look at the lead 3 and AVF, there is a very prominent ST depression. So inferior wall ischemia is present. Lead 2, 3 and AVF, they have got ST depression. And also you see there is ST depression in lead V1, V2, V3, V4, but V5 and V6, they have got none. So there is anterior and inferior wall, and anterior wall is on the right side, like V1 and V2 and V3, it is side of the anteroseptum. So there are chances that there is right coronary artery thrombus, because not only the inferior wall ischemia is present, but also anteroseptal ischemia. So there are chances that this can be RCA plus left anterior descending artery ischemia or thrombus. So here we see changes of the ST depression in not only inferior wall but also in anteroseptal, and going all the way up to the V3, V4. So LAD and RCA, they may probably have a thrombus. So this patient will be treated according to the acute coronary syndrome protocol, and cardiac enzyme would be sent to the labs. I've already discussed that there are two types of the cardiac enzyme. One are the troponins, and one is CKMB. These turn out to be positive or negative, are the final result after 4 to 6 hours of the chest pain. This is the qualitative test where it turns out either positive or negative. And another form is the quantitative where we get the result in digits, but it takes more time. So handy or bedside test is to get troponin I qualitative. There are two types of the troponin I and T. Troponin T is non-specific because it is also positive in cases of sepsis, ARDS, chronic kidney disease, surgery, DIC, disseminated intravascular coagulation, pregnancy, or trauma. But trop I is very cardiac specific. But when you are in doubt, like if patient has got comorbidities, better to get another set for the quantitative result. But when you here see the qualitative test, this is a trop I rapid test. There, when there is no line present, it is known as invalid. And when control is present and test is negative, this is a negative test. When both control and test, the red line, are present, this is a positive. Here you drop the blood. This test comes with a including syringe. So you take 3 ml of the blood, then you put the drops over here, and it takes only 15 minutes for the test to be either negative or positive. If along with those ECG changes this test is negative, we will call it unstable angina. But if test is positive along with the ECG changes and the risk factor and everything, then this is non-ST elevation MI.